Assalamu alaikum. I'm Dr. Asfandyar Khanzada, and today we will be discussing headaches. Headache is the most common reason why adults seek medical care. A broad range of diseases can cause headache. We divide headache into two broad components, which is acute and chronic. Acute headache is most likely to be of a vascular nature as compared to the chronic one. A careful history and physical examination should be our aim to identify the urgent causes of acute headache so that urgent medical care should be provided to that patient. We can divide acute headaches into the following subtopics: vascular, infection, intracranial masses, preeclampsia, and carbon monoxide poisoning. Vascular can be intracerebral hemorrhages, vasculitis, thrombosis, malignant hypertension, arterial dissection, or aneurysm. Infection we include abscess, meningitis, encephalitis. Intracranial masses can cause intracranial hypertension, which can give you headache. A lady who is pregnant present to you with headache, it can be preeclampsia, and if there is exposure to the carbon monoxide gases and a patient present to you with headache, it can be carbon monoxide poisoning. Physically, we will inspect three areas to examine patients with headache. The first one is monitoring the vital signs, going for neurological extensive examination, and testing with fundoscopy. Vital sign can be divided into the four components, which are blood pressure, pulse, temperature, and respiratory rate. Neurological examination will always be extensive in patient presenting with acute headache. So, when we start with the neurological examination, we start from eye, pupil field, and pupillary reflexes. Now we move towards lower limbs, in which we see the reflexes, gait, cerebral signs, and pronator drift. Vision with fundoscopy, in that we see the retina, we see the blurring of retina, we see the optic disc and retinal vein pulsation. There are some conditions which can give us the clues about our probable diagnosis and the cause of headache in those conditions. So, if we have a disseminated visual acuity which is generalized, it can be because of glaucoma and optic neuritis. Ophthalmoplegia or visual field defect can give us some clue about the venous thrombosis, tumor, and aneurysm. Apparent pupillary defect can be indicative of intraocular mass or optic neuritis. Pupillary edema or no venous pulsation while looking into the eye on retinoscope can give us indication for increased intracranial pressure. And when we get these signs from our examination, then we can go further with extensive laboratory and radiological examination and testing to prove our diagnosis, which reaches to severe discomfort in a time frame of seconds to minutes, is usually attributed as subarachnoid hemorrhage. Technically, the patient is complaining of having thunderclap, where very severe headache, and if you ask the patient grade the headache, he will always say 10 out of 10, or type of headache which he have never had in his life. Such headache increases when there is strenuous activity like coughing, Valsalva maneuver, and sexual activity. Second one, hypertension, headache, pulsation, sweating. This triad is usually attributed to the pheochromocytoma. If a patient is pregnant having headache, blood pressure, you can call it as preeclampsia, and it can be proven later on with extensive testing. Migraine, which is the most common in young age, and many people fall victim to these diseases, usually present with unilateral headaches, photophobia, nausea, vomiting, which are the hallmark features of this condition. Before we move to case discussion and to summarize this whole topic, we come to our last topic, which is how we will treat the acute headache. As we have discussed different types of acute headache, so treatment of each and every type will be different. Subarachnoid hemorrhage is something which is acute emergency. So if there is neurological unit in your hospital, refer the patient to neurological unit where they can intervene timely to save the patient from neurological, because brain is a very delicate organ. It is incompressible and very little space it have for compression. So whenever such kind of condition like subarachnoid hemorrhage, subdural hematoma, epidural hematoma happens, there is compressibility of brain. So when you refer the patient to well furnished and well equipped a unit of neurology, they can go for surgical intervention and can relieve this pressure early before some neurological deficit happens. So if you have a condition like pheochromocytoma, you can remove the adrenals, which will relieve you from the headaches caused by the pheochromocytoma. A pregnant lady with headache, preeclampsia, you can control the hypertension and she will be headache free till her term pregnancy. Migraine, which is most common in young people, by starting the patients on early NSAIDs and triptan, we can terminate the episodes of educate the patients regarding precipitating factor. So when precipitating factors are controlled, usually the migraine is controlled. Now we will progress to our case discussion, and which will be followed by summarization of this whole headache. A 25-year-old lady, gravida 3, para 3, presented with headache, vomiting, nausea from last 1 week. She is normotensive, normoglycemic, non-pregnant patient, no family history of headache. On examination, there is no photophobia, no nystagmus, no papillary edema, and it's not associated with decreased level of consciousness, no neck stiffness, no flushing of lines or zigzag lines. I have described that there is no photophobia, which means that this patient might have or not the migraine. No nystagmus cerebellar disease is ruled out. No papillary edema, which means that there is no increased intracranial pressure, not associated with decreased level of consciousness, which means that there is no infection in this patient. Neck rigidity can be because of subarachnoid hemorrhage, can be because of meningitis, encephalitis. So as this patient does not have neck rigidity, these conditions are also ruled out. No flushing of light or zigzag line, which means that there is no migraine. So our differential diagnosis in this patient was tension, headache, raised intracranial pressure because of vomiting, nausea on early presentation, and benign tumor. These were the three differential diagnoses in this patient. Now I will summarize different types of headache which we already discussed earlier. I will go through quickly, and in last I will tell you the diagnosis of this patient. Before jumping to the diagnosis in this patient, I would like to discuss and apply the formula Socrates to headache and give you clues about different kind of headaches from. If the pain is unilateral with zigzag lines and flashing of light, it indicates migraine. Generalized headache with vomiting and nausea indicates increased intracranial pressure. Generalized with vomiting and photophobia is meningitis. Persistent in temporal area give you the indication about temporal arthritis, and headache with pain in around cheeks, back of the eyes usually indicates sinusitis. Time and mood. If the patient complain of pain or headache in morning after waking up, it is increased intracranial pressure. Sudden severe headache, thunderclap. Remember, it is subarachnoid hemorrhage. Persistent for days, it is tension headache. Persistent pain in temporal region is temporal arteritis. Recurrent headache is migraine or cluster headache. Radiation section, we describe two kind of radiation in the headache. It's bilateral and radiating towards the neck and shoulder. It is because of and can be because of cervical spondylitis. Unilateral pain radiating to the jaw, neck, and along with the photophobia and zigzag lines, it's always indicative of migraine. Nature, as described earlier, that there can be different nature of this pain. So if the pain is throbbing, it is indicative of cluster headache. If it is tight band like, so it will be a tension headache. If it is severe thunderclap, remember, then it will be subarachnoid hemorrhage, and over the trigeminal area it will be the temporal arteritis. In our patient, it was a simple case, but the thing which was keeping us busy to find a diagnosis was raised inflammatory markers. We repeated the inflammatory markers which came to be normal. So that was the laboratory error which kept us busy for finding the reason of inflammatory type of headache. Our patient was discharged with medication of triptan and NSAIDs, and she responded to these. This was all about acute headache. I hope I made headache clear for you people to understand. If you have any question, feel free to ask in the comment section, or you can directly email me. Take care, be consistent, and keep loving medicine.